What I hear is a song. Okay. Can you ask the next person, how is this conference doing? I hear you. Another song. Okay. You know, there must have been an answer to how is this conference doing. I need one person to give me the answer from that, how is this conference doing? Okay, Beth. Beth, you want to say? You come. Give her a wonderful round.
This conference is excellent. There's so much unity, so much energy. It's very exciting. Thank you.
I didn't hear you people say, yay! Okay, please can you have your seats? We are going to start a session that is so important. And it's so important because we are looking at opportunities to increase domestic funding of family planning. The Minister of Health made a public declaration yesterday that in this 2017 budget, they are going to increase funding for family planning in terms of counterpart to 4 billion, isn't it? But you know, he doesn't have the knife, neither does he have the yam, isn't it? The person that has the knife and also has the yam is also coming here to make a public declaration of support of what the minister said yesterday. The chair of the Committee on Health, Honorable Chika Okafor, is going to come here to say the ayes have it.
Good morning once again, distinguished participants, ladies and gentlemen. This promises to be a very interesting session. It's going to be a panel discussion. But I also want to give you a slight introductory overview of what we're saying, what we're going to be talking about. We're going to be talking about global facility financing, global financing facility for every woman, every child. What does that mean? We're going to focus on preventable, reproductive, maternal, newborn child, and adolescent health. It was first of all announced in 2014, an initiative of the United Nations with partners. Like I said, focusing on RMNCAH. Now, it was launched in July 2015 in Addis Ababa, and it also has within it a highly strategic multi-sectoral approach, because we know that government cannot do it all. So you have government, you have partners, IHP+, H4+, we have CSOs, we have the private sector, all are involved. Now, it's going to be hinged on two big conditions. We're going to be having an investment plan for reproductive, maternal, newborn, and child adolescent health, as well as a comprehensive healthcare financing strategy. Now, back in Nigeria here, Nigeria was listed in July 2015 as one of the second wave countries to benefit. And at country level, we operate through a country platform which involves stakeholders in reproductive, maternal, newborn, and child health care. And for countries to benefit from the GFF, there's need to develop the healthcare financing strategy as well as an investment case for IMNCH. We also know that the GFF prioritizes issues that have been traditionally underfunded, like family planning, like nutrition, like civil registration, and vital statistics. So it focuses on needs of key populations that have been historically neglected. So for the GFF itself, we have between $40 million to $60 million. But $40 million have been allocated to Nigeria, and we are asking for more. And you'll still know why we're asking for more by the time we finish this panel discussion. We also know that the GFF has also approved to co-finance a national strategic investment plan for additional financing for the Northeast to the tune of $20 million US. And that additional financing is actually an opportunity to utilize that fund for the most vulnerable part of Nigeria, and potential for us to have returns on reproductive, maternal, newborn, child and adolescent health care is actually there. So after this brief introduction, the essence of this panel actually is to discuss the role of global financing facility in driving reproductive, maternal, newborn, child, and adolescent health care in Nigeria. We will also explore unique opportunities for improving cost-effective solutions like family planning in this country. So panelists will be discussing the role of mobilizing additional domestic resources for family planning within the implementation of basic healthcare provision fund within the National Health Act. So I want to welcome the panelists and ask them to introduce themselves one by one, starting from the right hand side.
I think it's still morning, so good morning, everybody. I said I think it's still morning, so good morning, everybody. It's still morning. My name is Ben Anyene. I'm the chairman of board of directors of Nigeria, and it's one of the people who are supporting this conference. So I'm invited to be here to be part of the discussion. As the chairman said, how do we mobilize local resources to pay for the country's needs? So thank you for inviting me.
Good morning, everyone. My name is Leslie Elder. I'm a member of the Global Financing Facility Secretariat, working across countries. Sorry, there we go. I'll start again. My name is Leslie Elder. I'm a member of the Global Financing Facility Secretariat, working across the 16 countries that the Global Financing Facility is now supporting. But we're delighted to be here in Nigeria with you as we have come on a mission. I am a focal point for the country of Nigeria among the various countries that are supported by the GFF. In full transparency, I want to tell you that my technical background is in nutrition, which we see as a very critical part of the GFF strategy, but I am not a family planning specialist, so I just want you to keep that in mind. Thank you.
Good morning, everyone. My name is Maletela Tuanenghasi. I'm also with the Global Financing Facility Secretariat, working specifically on civil registration and vital statistics, which mainly covers the registration of births and deaths, as well as marriages and other vital events. I'm delighted to be here. I've had some work on family planning many years ago when I was still studying. My PhD was mainly focused on family planning, and it's good to be back in this forum, and I'm glad to be here. Thank you.
My name is Celeste Carr. I'm a health advisor at USAID's Health Office. As many of you know, USAID's health program has broad interventions in child survival, maternal health, and malaria, and I'm very pleased to be here to discuss our programs with you. Thank you.
Thank you for that brief introduction. Just to take us through how we're going to structure this panel discussion. There will be a lead presentation, 10 minutes of lead presentation, and it's to get us in depth of what GFF stands for. Okay? That will be followed by questions from me to the panelists. Then, with time permitting us, we will also field questions from the audience, and then I will close the session. So let me call on Dr. Olumide Okunola to come in and give us a 10 minutes presentation on an overview of Global Financing Facility. You're welcome.
Thank you, Mr. Chair. I don't think I'll need up to 10 minutes. You've done an excellent work introducing what the GFF is all about. Just to perhaps highlight a few more points. Sorry. Yeah, I just made it. So there's been several questions on what the GFF is all about. First, the GFF is not a World Bank product. It's actually a partnership chaired and led by the UN Secretary General with a whole lot of partners and governments behind movements to reduce the high burden of debt amongst our mothers, amongst our children, and indeed to make our adolescents live a much more productive life. Indeed, with the events of the last 24 hours, the issue of domestic resource mobilization indeed becomes more important. Indeed, for this group of stakeholders. Many of us might not know the political economy of it, but from where I see it as a health financing person, the new normal will be countries will need to really start reducing whatever you're going to get from other countries. That's a reality. The GFF emphasizes smart financing. A lot of the interventions we either implement at service delivery levels or propagated by governments are probably very inefficient. And that's why, again, your constituency is very important, because perhaps one of the largest returns you can get on any intervention comes from family planning interventions. And those are some of the kind of things that the GFF aims to promote. Yes, the director already alluded to the first wave and second wave countries. I'll just quickly spend some time on the what, the how, and the who of the GFF. Basically, like the director mentioned, countries are required to develop investment cases for RMNCH. But you just don't develop an investment case in isolation. You must also develop that case in tandem with a financing plan. Otherwise, you just have an investment case that sits on the shelf and no one is able to finance it. It then means that when we're developing an investment case, we must be able to prioritize. We can't probably do everything, even as a country, but we want to focus on what are those interventions that gives us the biggest bang for the money? What are the things that can reach the people who deserve it the most? So a laser focus on prioritization is really, really required in investment cases. And I do hope the panel discussion will be able to, shed some light on where the investment case for the Nigeria program is. It would also be interesting to hear from you what the family planning community, how engaged are you with the ongoing RMNCH investment case being led by the Federal Ministry of Health? I know several of us are part of it, but we need to be actively involved. As I said, the health financing strategy needs to be developed as a complementary strategy to this. Basically, this is the burden of disease in Nigeria. 75% is within the RMN-CAH space. So what's other role for the GFF? If the GFF focuses on the RMN-CAH, then indeed for Nigeria, this is very timely. And I'm sure you see a flat line in terms of TFR, which I'm sure you've discussed over the last couple of days. Perhaps the GFF presents an opportunity to bring a rapid reduction in these static bars that we've seen over the last 20 years or so. So basically, just as I show these last two slides, several countries that have been far advanced in their investment cases have explored family planning in several ways, some directly and some indirectly. Some of the direct interventions that countries have used, the several of them on the slides, but I think you're in a better position to say this is what works best for Nigeria. I need not to emphasize again that it is what you bring on the table, what you bring onto the investment cases that will actually make a difference. Yeah. So now, the last slide. So I believe that Nigeria has a very huge opportunity with the National Health Act, more so with the Basic Healthcare Provision Fund in the National Health Act. Like I mentioned at the start, the implication of using Nigeria's own money to fund its own health activities is now more important than ever before. And beyond FP, beyond nutrition, we need to now start to engage our government officials to say, how much of our own money are we putting into our programs and plans? I hope Dr. Ayene will be able to give us an update on whether we're going to have the Basic Healthcare Provision Fund budgeted in FY17. Because if we don't start from that point, we're going to have a real problem going forward. Thank you very much.
Thanks, Dr. Kumola, for that very brief presentation. Now we are better informed what GFF stands for. The next thing for us to look at is for me to ask panelists certain questions. And when I ask them, it's for us to also get informed from their answers. I will start with Celestica from USAID. We're looking at prioritization of family planning within the context of reproductive, maternal, newborn, child, and adolescent healthcare investment case. So, in your own view, what opportunities do you see for addressing the huge family planning needs in Nigeria through reproductive, maternal, newborn, child, and adolescent health investment case? Thank you.
Thank you, and good morning again, everyone. Throughout this week's presentations, we learned of the health challenges Nigeria has experienced through the low uptake of family planning services, particularly issues of access and cultural barriers influencing the utilization of contraceptives among women. These challenges manifest themselves through low contraceptive use, resulting in high total fertility rates and increased threats of preventable maternal and child deaths. GFF will allow Nigeria to prioritize issues that generally have been unfunded or underfunded, like family planning. But I am not only advocating for family planning, I am also advocating for other issues that usually do not get funded or are often underfunded or unrealized, like programs focused on adolescent health. I mean, we heard some really insightful statistics just this morning on adolescents, the low fertility rates, the low CPR among adolescents, the fact that they make up 50% of the population here in Nigeria. We need to focus on adolescents more than we have been. Other opportunities include building high-level political support for family planning in Nigeria, expanding data use. We had some excellent presentations this morning on data. Now that we have the evidence, we can plan and prioritize our programs. Mapping resource mobilization, scaling up long-acting methods, with some discussions this week on the value of long-acting methods. Improving supply chain and delivery systems. Investing in supply-side efforts and behavior change communication. Behavior change communication, we heard from some of the information this morning how important radio spots and TV spots have in influencing women in contraceptive utilization. Also, increasing private sector involvement. 60 to 70% of Nigerians utilize the private sector. We need to engage them more in family planning and other interventions. Let me end by mentioning that accountability should be the watchword for any resources leveraged for RMNCAH, no matter what the intervention is, no matter the source of funds. Nigerian women deserve accountability for results, for resources spent and where. Every life matters, then accountability should matter as well. Thank you.
Thank you very much for the response to my question. I will call on the next speaker, Leslie Elder of the World Bank. Global Fund Financing Facility approaches to address family planning in investment cases. My question is, how is the GFF addressing family planning in investment cases and in GFF TF supported projects?
Thank you very much. I'm going to take this opportunity to look across the GFF portfolio, and as my colleague Dr. Olumide mentioned, so far we have 7 final or near final investment cases. They come from the countries of Cameroon, DRC, Kenya, Liberia, Ethiopia, Tanzania, and Uganda. And I think one of the advantages of the GFF is that countries can learn from each other and that we can support peer-to-peer learning and exchange of knowledge. Across the board, the GFF perceives, understands, supports family planning delivered in an integrated fashion through the continuum of care to be a critical intervention for RMN-CAH. As you've discussed, I'm sure, for many of the sessions over the last few days, it has very positive impacts on a whole range of outcomes that we're seeking. Reduction of pregnancy-related health risks, decreasing maternal, newborn, and child mortality, reducing adolescent pregnancy, and importantly, empowering women and enhancing education and employment opportunities for women. I wanted to note that of the 6 core indicators that we are looking at across all of the GFF countries, 2 of them are related to family planning. The first is adolescent birth rate, and the second is modern contraceptive prevalence rate. So you can see that we really strongly value the intervention and the outcomes that can be achieved through family planning. In the slides that Olumide put up, we captured briefly the approaches that we're seeing, again, across the investment cases, and which we will be looking towards the Nigeria investment case as well. We're looking at dedicated family planning interventions, both on the supply and demand side. We're looking at integrated delivery, making sure that it's part of the essential package of RMNCAH services, looking at how we take advantage of missed opportunities for antenatal care, postpartum care, and so forth. And then definitely looking at the broader sexual reproductive health and rights agenda. How can we ensure that comprehensive sexuality education, for example, cash transfers for adolescent girls, adolescent youth-friendly health services, and so forth, are embedded in the investment cases. Then we have the 2 indirect pathways, which again I think is part of the advantage, part of the value add of the Global Financing Facility. And that's looking at health system strengthening, because of course you need a strong health system in order to effectively deliver family planning and get the kind of results we're looking for. And then second, health financing. Through increased government revenues, through increased efficiency of allocations of government revenues, and then through improved resource tracking. In all of these ways, family planning is seen as something that we need to ensure is delivered across the countries that we're supporting through the investment cases. So finally, I thought it might be interesting for you to hear, in a very preliminary way, what are some of the challenges that we're seeing in terms of family planning in the investment cases. I think one of the main things that we're seeing, and I think this will resonate probably with the group, is that commodities access is often a very tough issue, and it's not necessarily elaborated to the extent that we need to see changes. The other one is adolescent reproductive health services, and this is a resounding need, not necessarily addressed to the extent that we want it to be addressed, but certainly seen as critically important. And I just wanted to share with you, and I think Margaret spoke last night at an event, so that the voice of youth and ensuring that youth are at the table for the production, for the design and the development of the investment cases, and then certainly for the implementation. We see that this is critical, and I think that youth are making themselves heard, want to be heard, and I think we need to harness that energy. And then finally, that there's still quite a bit of room for technical assistance and capacity building around, for example, tracking funding and expenditures, commodity access, and public financial management. So these are all things that perhaps the GFF can be a value add to the countries as they proceed to really make a huge effort and succeed in improving RMNCAH outcomes. Thank you.
Can I please call on Aminu Magashi Garba to join us on the high table if he's here? Okay. Okay. I understand that he wouldn't be here by now. What of Abdullahi Belel, the chairman of Adamawa State Primary Healthcare Development Agency? Is he here? Okay. All right. Let me call on Ben Ayene, Chairman HEFON. You need to tell us the role of the National Health Act. What role do you see for the National Health Act in improving poor maternal and child health indices through family planning?
Thank you very much. For those of us who have read it, I'm not going to do that exercise now to ask how many people have read it. When we discuss about National Health Act, most people focus on the Section 11, the Basic Health Care Fund. But actually, the National Health Act goes beyond Section 11 in assuring quality RMNCH. And I'm happy that the past two speakers have touched on issues of systems, because procuring the commodities does not solve the problem if you don't have the systems and infrastructure to deliver. And the systems include actually the HR component of it. And I'm also happy that somebody have touched on the private sector, because we tend to forget private sector when we discuss, we have this kind of conversation. But down southern Nigeria, private sector is actually delivering about 70% of healthcare. In the state where I come from, private sector delivers about 80% of services. So they are important. But getting back to the Health Act, yes. The Basic Health Care Fund of 1% contributes to raising local resource mobilization. But we also have to warn ourselves that it cannot solve the problem. If you go to that section, what it did say is 20% or the 1% we go to payment for vaccines, drugs, commodities, and others. So next year, what we're expecting, assuming that not less than 1% is budgeted, it will be bringing about 42 billion into the national budget. So 20% of 42 billion is about 8-point-something billion. But from the scale-up plan for family planning, the one for 2014 to 2018, the blueprint, if I'm correct, you will need about $122.5 million to pay for 2017. And that $1.2 million comes out to about 32.2 billion naira. And 32.2 billion naira, the money GFF is investing, the 60, I'm adding the Northeast and the National, which is $60 million, comes to about 17 billion. So there is a huge gap. And the question we'll be asking ourselves, how do we fill this gap? There are certain things we are trying to do, and I think I will share that with this August occasion. The first thing we have to do about how do we fill the gap is first, efficiency and effectiveness of utilization of resources. Even the little you are giving, is it delivering what it's supposed to deliver? Because the data is available that the donors contribute about 5 to 6% of national health spend. But that 5 to 6% delivers about 50 to 60% of health services in Nigeria. So how do we improve on efficiency before we even start to ask for more money? Then the second component of it is increase in budgeting, budget allocation. We've been campaigning not just for family planning, for MNCH. In fact, we even took the legislator to a retreat 2 weeks ago to Calabar, and that's what we are discussing. The CSO submitted an MTSS to government, and most of them are focused on MNCH, and there's a session on family planning. But it stops there, because we will still be asking within the fiscal space available to the Federation in paying for cost. So outside that, are we looking at other possible sources of funding? And that's what I think I want to say. So the point is, the National Health Act can complement but cannot solve the problems. National Health Act, the other 50% that is going through the National Health Insurance Scheme, he did say to provide basic health care for all Nigerians. That basic health care has not been fully defined, and I don't know whether family planning is part of it, because that will be another resource. But beyond that, actually there is a section in the health bill that says that the federal government must promote availability of good quality, safe and affordable and essential drugs, including medical commodities. It's in the bill. Most people don't see that aspect. It's not on that section 11. So there are a lot of things within the health bill that can help to augment local resources, even the issue of certificate of standards, because if the facilities have appropriate standards and these services are delivered, it adds to returns and results. But going outside that, these children, 7 million children are born in Nigeria every year, so they are born by mothers. And these mothers are not here in Abuja. They are out there in our communities, local governments, and states. So they belong to local governments and states. I don't know how many of local governments and states that are here. Is it possible also, out of part of this trying to fund, outside the provisions of the National Health Act, outside the provisions of budgetary allocations, to start to tax, let me not use the word tax, it's start to encourage states to take a second look at their budgets to see how they improve on the amount allocated to RMNCH. It's not just family planning. Because if you look at some of the state budgets, some of them don't even recognize that it's RMNCH. And we have to start to push them, because they're resourcing and mobilizing. So, in conclusion, what I'm trying to say is that yes, the National Health Act can act as a catalyst for funding. And for it to act as a catalyst for funding, all of us, especially with the Nigerians, must push for its implementation. It was passed in 2014. It was not brought on budget 2015. It was not brought on budget 2016. Even 2017, we are fighting almost what I may call a losing battle to bring it on board on 2017. We are not yet assured, but we are working. And I wish the guy from National Health Assembly is here, because it's some of the things we are discussing with them. So in summary is that we have to pull resources from the National Health Act, improving the efficiency of budgetary allocation and performance, working with the private sector, as has been rightly said, and also ensuring that states are co-funders for RMNCH activities. And in doing that, It will help us to reduce the pressure on the federal level, because I have to be very frank. If you go to budget and planning, what they will tell you is that they just have this resource envelope and they cannot go beyond that. So if they cannot go beyond that, I don't think, in fact, Nigeria should be working towards working out the donors into funding RMNC. Now, Nigeria had the resources to do that, but we have to be able to try to capture those resources to support this. So National Act is there. There are provisions there that can help to catalyze local resource mobilization. It has to be properly managed. There have to be structures for that management and things like that. Then the systems have to be strengthened, including financial management system. It's not just the human resources component of it, so that we can get value for money. Thank you.
Okay. All right. I think at this point in time, we may want to ask for questions from the audience. I think we have a little bit of time, and I know we want to engage the panelists in discussions and questions. So the floor is open for us to entertain some few questions, albeit within our time limits. Can we have somebody pass the mic around? For anyone can raise up a hand for recognition, and then you can ask us questions. Oh, okay. Sorry, before we entertain the audience, I understand that there's still someone here that actually has not spoken. I want to apologize for that, and to also ask us that we take her response before we throw to the audience. Okay. She wants to speak. So, Malitela, permit me to introduce you from the World Bank. In which ways, you see, civic registration vital statistics is very, very important to us. What it means is that if you are not counted, you don't count. So she's going to be talking to us in which ways can civil registration and vital statistics be used to promote women and child health through family planning in the reproductive, maternal, newborn child, adolescent, healthcare investment case. Thank you.
Thank you. And the Global Financing Facility also prioritizes civil registration and vital statistics, which we normally just abbreviate as CRVS, mainly to help us measure the results in reproductive, maternal, newborn, child, and adolescent health. In a well-functioning CRVS system, that is, it's a system that will register all births that occur in the country, all deaths that occur in the country, as well as the marriages and divorces and other vital events that occur in the country. It also makes sure that those who have registered also get certificates, whether it's birth certificate, death certificate, or marriage certificate, but it also ensures that at the end of that process, there's a compilation and dissemination of statistics that also includes the statistics on causes of death. So the GFF has prioritized this because we are able to get our information on infant mortality rate, maternal mortality ratio, and other health indicators. But CRVS mainly serves two purposes: one of providing legal documents and also providing vital statistics, including socioeconomic and other demographic characteristics. That is, when a woman registers the birth of a child, we also collect characteristics of the mother, her other pregnancies, and methods of delivery, and other things at the time of birth registration. In addition, at the time of death registration, we also collect information on the causes of death, for deaths that occur in the facility as well as deaths that occur out in the community. Now, first starting with birth certificates. This follows registration of a child after birth with the Civil Registration Authority. The birth certificate as it is provides legal status, which allows individuals to access social services, which can include family planning services, especially in countries where such services are free to citizens. So if you have that document, then you are a legal citizen that can access social services in the country. In addition, in countries where family planning, I don't know if there are any of such countries, is offered for women of specific or men of specific ages, then you have a document that shows your age and therefore your eligibility for such kind of services. But it also provides evidence of age, which can be used against early sexual activity as well as early marriage, and protect the rights of young women. We had the story yesterday that Margaret gave of Aisha, where marriage happened early and childbearing happened early. So in a country where there is a legal age for marriage, then you will have a certificate that proves your age. And where also marriage registration is compulsory, then at that point you are able to identify those ages that are not, those young women that are not eligible for marriage. And in that way, it can postpone the need for family planning services if you are able to postpone sexual activity as well as marriage. In addition to that, we have CRVS providing data in real time and at the lowest level of geography. So if within a short period of time a birth is registered or a death is registered, then you have that information available throughout the country. And family planning requires data by age of mother and the number of children a woman has had for planning, implementation, and monitoring and evaluation of family planning services. From a functioning CRVS system, you're able to get the distribution of births by birth order. That is, you'll know what is the birth order of the child that is being registered. And in this case, you're able to identify areas of high birth order where substantial interventions for family planning are required. But in addition to that, you get information about birth interval because you collect information about the current birth and as well as the previous birth. And in this way, you are able to identify those areas where you have short birth intervals, which may affect the health of the current child, the previous child, as well as the health of the mother. So you are able to identify those areas in real time and at the lowest level of geography which we need for planning. Specifically going to the causes of death, if that information is collected, we are able to get information on causes of death that are related to pregnancy or childbirth. And we have that by age. For example, we can get where cause of death is induced abortion, for deaths that occur in health facilities or those that occur at home. So in this way, you're able to identify high-risk populations that you need to for intervention. So family planning contributes significantly to the prevention of maternal and child mortality, and real-time data is available at lower levels of geography, which you can get from the CRVS system. And this information is needed for planning, monitoring, and evaluation of family planning programs. And I wish to take this opportunity through you, Chair, to advocate for mothers and fathers to make sure that their children are registered, that children have birth certificates, as well as making sure that the deaths that occur in the country are also registered. Thank you.
Thank you so much for that interesting. Given the limit of time, can we ask for one or two questions from the audience? We will introduce someone who came onto the high table while the session was on. Some of us will have recognized him, but some of us may also not know him. So I'll give the phone to the chair, the co-chair, to please do the introduction.
Thank you. Morning again, ladies and gentlemen. It's my delight, in fact, and honor to introduce the gentleman that just walked in here. His name is Honorable Chika Okafor, and he is the chair of the Committee on Health at the National Assembly in the House of Representatives. I want you to clap more, and I will tell you why. He's also the chair on ad hoc committee on non-oil revenue and remittances. And you know how that is so important for us as we have a monoculture and we're in a resource-rational economy. He was also a former commissioner of finance in Imo State before he came to the National Assembly. Why I'm so excited that he's here today is I noticed that he had the, should I say, the interests of the Nigerian women. When under the PACFA project, we did an assessment of the 2016 budget. And then we looked at maternal, newborn, and child health budgets. There were 3 line items that speak to those issues. One was the midwifery service scheme, which we know had tremendously reduced maternal mortality in the country. The second was, in terms of immunization, the money allocated to the National Primary Healthcare Agency for immunization. And then the third one was money for family planning. Sadly, so at the time, but now I'm happy, no money was allocated to the midwifery service scheme. No money was allocated to family planning. And the money that was allocated to National Primary Health Agency, 15 billion, only 4 billion was for purchase of commodities, and the rest was for logistics. So we got alarmed. The Association for the Advancement of Family Planning and the ACFA project, we made a presentation to him. He listened to us for 2 hours, very keenly, asked very straight questions. And you remember, there was a problem at the National Assembly at the time. The House had said the only budget they were going to look at is the one submitted from the President's office, that it was unconstitutional to entertain any other budget. But by the time we explained to him, he swung into action. He got all his colleagues, convinced his speaker and everybody, and that was how the House now said the MDS should resubmit some of those things. Please welcome Mr. Speaker Ekaupo. Now we have 1.2 billion in the midwifery service scheme. We have 760-something million in the family planning. As at that time, it was $3 million. But, Honorable Sir, you know that 700 and something is no more 3 billion at the time. And then they disaggregated again the primary health agency budget. Only 2 billion was now for logistics. The rest was to help pay for our counterpart funding. So he is already with us. He is already one of us. And that will tell you, Gates Foundation met him yesterday. And he's here with us. Please welcome Honorable Chika Ekaupo.
Thank you very much, the Chairman of the Local Organizing Committee of the 4th Nigerian Family Planning Conference 2016, Dr. Ejike Orji, a great son of Nigeria in general, and permit me to take him home, a great son of my Igbo client. The co-chair of the panel, Dr. Akin Oyemakinde, selfish, and now I can see a former member of the House of Representatives and chairman of House of Reps Committee on MDG at the time, Honorable Sadatu Sani. My pleasure to see you here. Your Royal Highness His Royal Highness Dr. Yamaya, the Emir of Shonga. It's my pleasure to have you here. And also, all the way from my state, one of our very respected traditional rulers from my state is AFC Emetuma Ofo Kingdom. The development partners, I understand you said, is here. And of course, the recurring decimal, that's what I call the Bill and Melinda B. Gates Foundation, and other development partners here present. I understand that some commissioners of health from some of the states, Plateau, Anambra, Kaduna, Bauchi, Rivers, and Nasarawa, I understand you're very much here. That tells you that the states are not paying lip service to the issues that are being discussed in this conference. Members of the Board of Trustees of Association for the Advancement of Family Planning, distinguished ladies and gentlemen, it's my pleasure to be here with you today to deliberate, discover, and intervene on the advancement of a very important aspect of our health sector, family planning. I must appreciate ACIOE Associates for organizing this robust program, your partner, the Bill and Melinda Gates Foundation, for being on the front line of strong advocacies towards promoting and strengthening maternal nutrition and child health in Nigeria, and other stakeholders present here today in coming together to deliberate on possible areas of collaborations and interventions that will push our country towards achieving have family planning goals. Their goals, a popular saying that a nation thrives when mothers and children survive. Therefore, family planning is an aspect of maternal and child health that cannot be overlooked anymore due to the high rate of maternal and child mortality and morbidity that occur yearly. Lack of access to a comprehensive family planning information and education, we all know, can lead to unplanned pregnancies, unsafe abortion, as well as financial hardship to women and families. Motherhood, of course, is a positive and fulfilling experience, but this experience to many women can be associated with untold suffering, hardship, ill health, and even death. Hence, a woman's ability to space and limit her pregnancies has a direct impact on her health, well-being, and educational attainment, as well as those of her family members. In addition, family planning plays a crucial role in population growth, poverty reduction, and human and economic development of a nation. In Nigeria, we must acknowledge the efforts of the federal government in addressing healthcare issues, particularly the maternal, child, and all other reproductive health issues through the implementations of policies and programs such as the creation of Midwife Service Scheme, MSS, policy on free contraceptives and life-saving maternal reproductive health commodities. The creation of budget lines and increased funding of family planning activities have also been considered. However, Nigeria still faces some challenges in bridging the gaps currently faced in the area of sexual and reproductive health, as well as in meeting the unmet needs for family planning. According to WHO, Nigeria is lagging behind on birth control implementation at 8% against the expected 15%, based on the support they receive externally and internally for family planning services. This can be attributed to inability to deal with the ever-growing population, poor data collection and monitoring system, cultural and religious barriers, lack of proper family planning awareness, education and lack of other structural considerations, such as poor delivery of healthcare services and infrastructural gaps at primary healthcare level. In view of the above, there is need for concerted efforts from not only the government, but also from all other stakeholders of health and other key development partners to continue to support the federal government in improving the family health of our nation, thereby striving to keep our women and children alive. Family planning must be repositioned, promoted, and strengthened, and we must strive to push beyond the barriers of religion, culture, demography, discrimination, and lack of awareness. I wish to use the opportunity to once again appreciate all stakeholders present here today for your contributions towards the improvement of maternal and child health in Nigeria. I wish to reassure you all of the mandate and commitment of the 8th Assembly under the leadership of Speaker Ratuno Yakubu Dogara in advancing maternal and child health in Nigeria. For us, there is no going back of it. On my part, as the chairman of the House Committee on Health Services, I will ensure that necessary legislative supports are given to the minister, to the ministry, and to all stakeholders to guarantee adequate funding. Even if we have to do it and they say we are padded, we will pad. Even if we have to do it and they say we have inserted, we will insert, so long as it has to do with the health of our mothers and children. We will insert funds, we will pad funds to ensure that budgetary allocation, sustainability, and timely release of funds. These are two different issues. I was discussing with the team that came to my office. I said it's one thing to put $4 million in the budget. Another thing is also to follow through and ensure timely releases of these funds. It is also our responsibility as the People's Parliament to ensure and to follow through that such important budgetary provisions are made, and also that the funds are released. And we also have oversight function to also make sure that those who ought to utilize these funds do so very well. So I'm standing here and I'm making this commitment that we are committed to that extent. We will go beyond just appropriation. We will see to it that the funds are not just allocated, but the funds are released and the funds are utilized accordingly. And also sustainability and timely release of funds for projects and programs to ensure strengthening of family planning in Nigeria. For us, there is no going back. Thank you so very much. And God bless you. Thank you for the opportunity. I wish I can stay in. I wish I can stay in, but I have asked one or two of my staff to stay so that they can get some of these details so that I can help us in our work. Mr. Chairman, permit me to take my leave at this time so I can go to continue with other legislative assignments. God bless us.
Clap. You know, let me tell him a promise made to the CSOs and the development world is like a promise made to an elephant. We're going to come after him. But I'm going to use this opportunity to call on Hajia Saada Tusani to please come and thank our honorable member for coming here and making this public declaration. Hajia, please come and thank him before he leaves. Hajia has been staying the course, leading the charge, and amazing in reproductive health and rights of women. Thank you.
The chairman of this session, distinguished members of the panel, good morning, good afternoon. My colleague from the parliament, let me, on behalf of all the participants, thank you for making it out to come and attend this important session. I understand today is Wednesday, and you have sitting. It takes a committed parliamentarian to leave the sitting to come out here. I'm very happy that you said you will pad it, you will follow it, you will also ensure its release and usage. What I've always said is that people do not understand the word pardon is highly politicized. In the Nigerian Constitution, the Parliament have the right to check the proposal of the President. They have the right to change it so that the constituencies or the people can be served. They have the right to follow it and to monitor the budget implementation. I'm happy as the chair of the Health Services Committee, you have agreed here, you have made a commitment with the Nigerian people that you will look at the budget, you will pad it, you will put it, you will ensure it is there, you will ensure it is there, you follow the ministries to make sure it is implemented, and you also follow the ministry to make sure that money allocated are being utilized for the purpose they are given to. Only responsible parliamentarians will do what you said today. Yeah. And I hope God Almighty will assist you to do that. We, on the other side of the divine, are watching you. We will also help you. We will tell you what is happening. We will tell you what is not happening, because that, when you go to the smaller chambers, people are very busy. So you may not know what is happening. We will support you. We thank you on behalf of Nigerian women and children. On behalf of everybody here, we thank you, Honorable, for making it this morning to attend this program. Thank you very much.
I was going to tell us, 2 weeks ago, I took a motion to the floor of the House of Reps. And we're looking at the challenges and issues surrounding our primary health care system. And then I've been in constant touch with the ministry. I've been in constant touch with the agency that is responsible for primary health care in this country. And I'm also on ground in our villages, in our homes. And there's no gainsaying the fact that the PHC system is completely collapsed. It is not working. I don't need to be a doctor to know that if we have a functional PHC system, then the pressure on the secondary and tertiary facilities will be drastically reduced. Because I understand and I know that 70 to 80% of diseases are treatable at that level of a system. But incidentally, we have been paying lip service to that level of health care. And I have also been talking with the minister who is highly committed to delivering in this area. But I also know our Nigerian system, and I also know the handicap and constraints that he's facing. So I felt that if we start from the House of Reps, from National Assembly, and begin to give that legislative support, it will help him, it will embolden him. So I took that motion to the floor, calling for declaration of state of emergency in our primary health care system. And it was unanimously approved. And one of the prayers is that we should go and conduct a public hearing, engage all of us. So come 22nd and 23rd of this month, we are going to have a public hearing that will address the issues of funding and lack of it in that level of healthcare service. So please, I'm using the opportunity to invite us. You will get the notices, you will get the invitations, but I said I would not, to be a disservice to us and to our nation if I failed to use this opportunity to announce that and tell you that this is where we are. And the next thing we're going to do, you will hear, I don't know if you heard about this one I just mentioned. Some of the people that came to my office, in fact, they said that's why they came, to thank me, because they read it in the papers that the motion was timely and was coming at a time that that's the only thing and one thing we should address. If we can address that challenge, then we have almost done half of the issues that are facing our nation, because health is wealth. Now, we are going to, the next one we're going to face is national health insurance. We're going to face national health insurance. We're going to look at the activities of the HMOs and service providers. We're going to make sure that the monies they get every month or every other month is used to fund or finance health service delivery. We will not stop at anything. Only God in heaven knows why we are where we are today, even when we are not doctors. So we will grab the opportunity that we have to ensure that the change that we all prayed for, the change that we all voted for, is also reflected in service, our health service delivery in this country. Thank you once again, Mr. Chairman.
Everyone, my name is Mary Sharif. I'm the Family Planning State Coordinator in Sokoto State. We have different methods of family planning. We have the implant, we have the oral, we have the injectables, we have what have you. But what about the men? The men is only male condom and vasectomy. When we talk of male condom, hardly you see a man with his wife using condom. The only way, if he wants to have pleasure outside, he will use it because he doesn't want to get infected. And then what about vasectomy? With all the awareness creation, with all the counseling, I have never witnessed a man coming willingly for vasectomy. So please, we are appealing. We need more method of family planning for the men. Thank you.
Your comment is very, very exciting. It's a comment, and you could see the audience reacting to your comment. Thank you very much for that comment. It is well taken. One more question, final question. Yeah. Comment.
Thank you very much for this GFF platform. I don't know if Dr. Olumide is still here, the World Bank team, if they are still here. Now, we're looking at making a case within the GFF. And I'll say my comment is that we've already made a case. Nigeria has the costed implementation plan. All we need to do is take it as Director, Planning and Research, where GFF is domiciled in FMOH coordination, take it as it is. It is a package that's already there. So we don't need to waste time on doing any costing again. Just take that and integrate into the matrix. So really, the work has been done. This is the time now
to put it within the financing matrix. And unfortunately, the parliamentarian also had left. I'm not sure he's aware that this costed plan is already there. And so put it within the box and let's add up the figures and let's know we've actually gone ahead to let you know year by year how much resources is needed to deliver that package of priority. So we've done, this community of practice has done that work. So just get out the money and let's begin to move. Thank you.
I just want to point out one fact, that plan that you said you have ends in 2018. The National Strategic Head-on Plan 2 that we are developing will end in 2021. So you still need to do some work to update it and incorporate it in the plan. And what we're doing actually at the moment, now is the time for us to work together, ensure that it is part of the NHSDP2, which is an investment plan for the entire health sector in Nigeria. So not much work to do, half of it is already done. Okay, thank you very much. Let me just round up. This is a very interesting session. Celestine Carr told us about the opportunities for addressing family planning gaps within the context of reproductive, maternal, newborn, and child health. And she observed low contraceptive use as well as high rate of maternal death in Nigeria. But she saw global financing facility as predictable, sustainable financing for family planning, especially if we're able to get the domestic funding aspect right. She asked us to focus on adolescent health. Adolescents forming 50% of the population of this country, and that we need a high level of political support for this to happen, for family planning in Nigeria, and that we need to scale up long-lasting methods, and that we need to look at the supply chain commodities, movement of commodities, okay, and that we need a private sector involvement because they offer close to 60% of services in this country. And she ended by saying accountability for results. We should all be held accountable for the result that we are seeing. Now, let's leave what let us look at how global financing facility will address family planning. And she said that global financing facility will actually support family planning delivery in an integrated fashion through the continuum of care, and that it will lead to reduction in pregnancy-related deaths and enhanced education and employment opportunities for women. She actually said that two indicators are addressed by global finance facility, which are the contraceptive prevalence rate and adolescent birth rate, emphasizing again adolescents. And that we need to also look at the supply chain of commodities. And we should not ignore health system strengthening issues, issues of human resources, issues of health infrastructure, service delivery. We should take it very important. They all impact on the effectiveness of family planning delivery. Then she also looked at healthcare financing issues. How do we increase government revenue to ensure that we have efficiency of allocation and that family planning needs to be effectively and efficiently delivered. Now, Dr. Ben Ayene here looked at the role of National Health Act in improving poor maternal and child health through family planning. He also spoke extensively on health system component of service delivery and also private sector importance. See, so many things are getting repeated. Health system issues, private sector issues, and filling of gaps in family planning service delivery will entail improving on efficiency of allocation before we even ask for more money. What we have now, are we allocating it efficiently? That's the question he asked. And that we need to have increase in budgetary allocation. There's no doubt about that. That has been complemented by the Honorable. And that the National Health Act can only complement. It does not solve all the problems. It can only act as a catalyst. And we must all support its implementation. Since 2014, we are still trying to grapple with implementation plans. But he assures us that work is going on to ensure that at least that 1% consolidated revenue fund is given out for basic healthcare provision fund in 2017. And that all states should be co-funders, that we should not leave the pressure on Federal Ministry of Health or federal government alone. Malitela that left spoke interestingly on civic registration and vital statistics, that it helps us to make better decisions, and that all births should count, just like all deaths should count, with certificates. And that we shouldn't stop at that, we should disseminate statistics. Infant mortality rate, maternal mortality ratio should be disseminated to the policymakers for action. And that the birth of the child alone actually allowed vital statistics to be collected on mothers. And that the civic registration and vital statistics will actually entail collecting information on causes of death and also causes of maternal death, death in children, death in the mothers, and that we also look at the distribution of births by birth order. And in doing that, it's also looking at the health of the mother, so that we can get real-time data to be able to plan with. So lastly, maybe I should just echo the words of the parliamentarian, that a nation thrives when the women and children survive. And that the role of family planning in growth, in economic growth, in maternal and child health cannot be ignored. And that despite efforts, government efforts, speaking from his own angle, that there are still gaps that exist in family planning service delivery. And that we need to, he advises that he and other parliamentarians will ensure budgeting release, insertion, padding, and the rest. And to ensure that he will also follow through to ensure that we not only have appropriation, release, and utilization accordingly. So thank you, I have rounded up, and this will be the close of the session. Thank you for listening, thank you for your patience.
like one lecturer says at his lecture, you can doze, but please don't snore. We don't want you to do that at all. It's going to be a very interesting session this morning. We have just 1 hour and we'll try and keep to the 1 hour. And the essence of this session is to intimate you on the challenge initiative against foundation-funded projects that gives us an opportunity to go to scale with what we have done with reproductive health in Nigeria, specifically the Nuri project. It's not taking place only in Nigeria, as we're going to hear. It's happening in other parts of the world. We are happy that these last few days we have been told about the very impressive progress we have made with reproductive health in Nigeria. Now we really need to go to scale. We need to take ownership of the project in order to ensure sustainability. I'm sure you know that most of our problems, particularly in the health sector, is we start very well, but within years it begins to wane. Somewhere along the way, we have not taken ownership. And that's why I'm very happy that the commissioners are here. I wish we had more commissioners, but we will have other avenue of reaching out to them. And for the commissioners, we will be asking you to give your commitment, specific commitment that we can hold you on at the end of this presentation. Don't worry, we will not get you to do what is impossible. So, ladies and gentlemen, to set the ball rolling, I'm sure you are wondering, what is the challenge initiative? We know we have a challenge, yes, but what is the challenge initiative? And to tell us about that, we have Jose Rimon, and we're just thinking about trying to change the schedule of the presentation because we know that Leicester has to catch a flight. But we want to lay the foundation, lay the basis, tell us what the challenge initiative is all about. So I will yield the floor to Yvonne to tell us about this initiative. Thank you very much.
Thank you, Madam Chair, and thank you for joining us. I don't know if Professor Ladipo is here, but believe it or not, I've worked with Professor Ladipo 30 years ago on family planning at University of Ibadan. We have the same gray hair. I say that because I still feel like a young person being associated with this challenge initiative. It is one of the most groundbreaking, innovative projects that I have ever been involved with. And I have probably been involved with more than 500 projects around the world. So let me start by just sharing with you why the Challenge Initiative and why it is so groundbreaking in scaling up reproductive health solutions for the urban poor. Next slide, please. Rapid urbanization, the future of cities. Next slide. By 2030, 470 million urban women will be of reproductive age. a 50% increase in 2015. By 2050, 70% of the world's population will be urban residents, according to the UN projection. Next slide. For Nigeria, the proportion of women living in the urban areas increased from 1990 to 2013 from 25 to 42%. By 2050, an additional 210 million people will be living in the urban regions of Nigeria. Next slide. This is a UN projection slide. The first one, you would see the decline in the numbers of people living in the rural areas and the increase of people living in the urban areas in Nigeria. Nigeria by 2050 is close to 70% urban. Look at that other slide. Nigeria will actually surpass all of Africa in terms of being the most highly urbanized country in the world and in Africa. So this project that was started with support, generous support from the Bill and Melinda Gates Foundation, is trying to see what can we do now to anticipate this huge change that's going to happen between now up to 2030, when most of the people would be moving into the urban areas, and many of them will probably live in urban poor settlements. So there is good news for Nigeria. Next slide. Your adolescent birth rate has decreased. That's good news, although it's still high. There's a 40% decline in maternal mortality, although it's still high, but the decline is there. And in the session this morning that you have, the findings of PMA 2020 showed that finally, after almost 15 years of flatlining in terms of achievement, it is beginning to change. The momentum is with you. The changes overall has been impressive, in my opinion, as well as all the other states that have been actually measured. All were going up. So what is the Urban Reproductive Health Initiative? Okay, next slide. So this is a global program first funded by the Gates Foundation between 2009 and 2015. It was tested in Nigeria, Kenya, Senegal, and India. In all 4 countries, next slide, there has been rigorous longitudinal evaluation that showed huge increases in modern methods of contraception across all countries, especially in Nigeria, by around 3% a year. You know what 3% a year is. In our business, if there's an increase of about 1% a year that is with good support, that's already good. So 3% is 200% higher than the usual. It is spectacular. So now, the challenge initiative itself. So once this has proven to have worked, how do we scale this up globally? Within Nigeria, outside Nigeria, what is the best way so that the learnings, the best practices, the tools, everything that we have learned can be adopted in various cultural settings in various countries to address the issue of the urban poor. So TCI will contribute to the goals of FP 2020 in the short term and universal access to reproductive health by 2030. It will build a framework, next slide, for providing development financing and technical assistance that has never been done in our business ever, scaled up, especially if you put them together, it has never been done. And you will see it in a moment. So first, TCI is what we call business unusual. This is not the usual business, the same old thing that we do year in and year out and expecting a
as different results. The original URI project, which was implemented in 4 countries, it was a proof of concept. Lots of money was put in them. It was a full package of interventions. It was very intensive technical assistance. And the pilot cities, or the first cities, were chosen. They were chosen. TCI is a different approach. This is now not proof of concept, but proof of scale-up implementation. 1. 2, it will be a minimum package with trying to implement the best minimum package, but achieving similar results. In other words, achieve more with less investment, but the right and appropriate investment. Third, the ownership really would belong to the cities and the geographies which would be part of it. Therefore, the technical assistance would really be streamlined. We normally use the 80-20 thinking on this, where a lot of research around the world has shown that sometimes, in many countries, you can achieve 80% of your objective because only 20% of the facilities are actually delivering those services. So you have to be smart about this. And finally, part of this business unusual is that the cities will self-select whether they want to become part of this initiative. So let me just show you again what are the key groundbreaking innovations that, now go back to the last slide. There you go. Okay. So first, and this has not been done in our business for a long time, the concept of self-selection or a demand-driven approach. In other words, the cities can participate. We're not going to choose them. They will take a look at TCI, appreciate what it can deliver, whether it's appropriate for them or not, and then they decide whether they would like to work with TCI through an offer of expression of interest. Okay? But in the process of showing their interest, they will have to show political commitment to work with TCI and bring the resources to the table. And those resources could be existing resources, assets that you have in your community, in your city. Maybe the other donors there who are willing, to collaborate with TCI. So that you show your readiness to work essentially with TCI. Second, if you become part of TCI, in terms of the expression of interest, and it would be competitive, not every city will be selected in the first round, okay? You will have access to 2 types of funds. The first is a technical assistance package that will be delivered by accelerator hubs in your country. In this case, it would be led by Nuri, and Moji is here. And at the same time that you have access to this free technical assistance package that will be funded by the Gates Foundation, you will have the opportunity to access a challenge fund, which would fund program delivery and program operations. The Gates Foundation has kindly put seed investment into this challenge fund, and we are committed as a consortium, including the Gates Foundation, to raise more money into this challenge fund. And we're looking for partnership with high net worth individuals around the world, and also here in Nigeria. These are private philanthropists, people who have made their wealth and are willing to give back to society. And maybe many other sources of funding that you may have even not thought about, which I don't have time to discuss here. Third, the approach to this is like you are a venture, it's like angel investing, We will provide seed money for the Accelerator Hub, a core money, and as they bring in more cities as part of TCI, their funding for technical assistance will increase, and they will have access also to the Challenge Fund, which means their funding for program delivery and operations will accordingly increase. So it's very entrepreneurial, in which the expansion only happens when you show proof that there are more cities participating with TCI. Fourth, think of McDonald's. If you were applying for a franchise for McDonald's, you are required to attend a McDonald's university. Every franchisee. There you get trained. When you go to a McDonald's franchise, for example, people will say, "Good morning, sir, what can I do for you?" Pick up your pieces and throw it in the waste basket, right? You go to the toilet, it's clean. Those things did not happen by themselves. It's part of the training when you go into a McDonald's university. So in this case, we have adopted that concept that if a city qualifies, they go through a TCI university where they will be shown the toolkits, the best practices that has worked here in Nigeria, in other countries, as well as the toolkits that USAID has developed over 30 years, what we call high impact practices, and they decide which of those are the most appropriate for their own setting. And finally, here, because we will be talking with high net worth individuals, sometimes that's a shortcut for billionaires, right? Or multimillionaires. Efficiency, effectiveness, and cost benefit is going to be built into this project. What do I mean by that? So if my friend here is a billionaire and is willing to invest in this, we have to show the billionaire what is his return to investment on this. So we would say, "Sir, at the end of 2 or 3 years, for every modern method user in this project in your place, it costs $12. I'm making this up. It would cost any number. $12, right? But, sir, the same $12 created a functioning supply management system that will continue to operate beyond potentially the life of the project. That's a system change. The same $12, sir, put in place a routine screening and referral system where everybody who goes to the facility for immunization gets screened for family planning and referred to appropriate service. If that's a system change that could go on beyond the life of the project. If you go to a facility and you get good client-provider interaction through counseling, and that becomes routine, that's also a system change. Your $12, sir, not only delivered a one modern method user, but all these other system change. So that's the kind of thinking that we would like to bring to this project. I'm not going to express some more on the 2 other points, but let's move on to the next. So just desired outcomes. First, we want the toolkits and the best practices that have already been well documented with evidence to have worked. We want them positioned for widespread adaptation. But the adaptation will be made, and the selection will be made by the cities themselves. Okay? Increase the number of cities replicating and adopting URI intervention. Again, here, it's demand-driven. One experience we had in Indonesia when we put something in place, the largest privatization program in the world on family planning, the Blue Circle program, we started with 3 cities in the first year, another 3 cities in the second year. By the third year, 300 cities in place. And the reason for it is no city in Indonesia would like to be left behind. Everybody wanted to be part of it. Everybody wanted to be a model city. And that was just an incredible experience. Again, improve program and resource sustainability in those geographies, meaning, again, how do we make sure that the resources are there, not only from the city, but if there are other innovations in your place, like cash transfer program, access to health insurance schemes, local private philanthropies, and some other funding, from other bilateral or multilateral institutions, those all could be put together, if wished, in order to improve sustainability. And of course, at the end of the day, increased use of voluntary modern contraception is the outcome. But we don't stop there. If we prove, and with encouragement from the Gates Foundation, that in the first 2-3 years, this works for family planning, then maternal neonatal child health folks may want to buy into the platform. Maybe primary health care folks may want to buy into the platform. Maybe our nutrition colleagues may buy into the platform. But only after we have proven that it has worked for family planning. Next slide. So here's the TCI consortium. The Gates Foundation is the initial seed funder of this. The Gates Institute at Hopkins is the global coordinator manager of the entire enterprise. And we have identified, for now, 4 accelerator hubs. One covering all of Francophone Africa, that is Intra. CCP Nuri for Nigeria. Nigeria is such a high priority and very important in TCI that it's only Nigeria, no other country, for this particular hub. Third, Jopaigo is for Kenya, Uganda, and Tanzania. We have identified PSI for India. And if needed, as we expand over time, maybe another organization or maybe ask an existing organization to cover other territories that may become part of this. So the demand-driven model, and this is very important, especially for my colleagues, the commissioners of health here. First, as you can see here, stage 1 is an expression of interest. As part of that expression of interest, there are 6 criteria that might be looked into in stages: political commitment, resource contribution, system readiness, the soundness of the proposal, cost efficiency, and the size of potential impact. Okay? So once you have passed stage 1, you will now in the stage of being asked to develop a simple proposal. If I were the one only making a decision on this, a 2-page proposal is enough. We don't want this to be a highly bureaucratized process. You can add attachments, but we want this to be a very simple proposal. Okay? So, but before you can do that, we will ask you to become part of TCI University, where you will be exposed to all the toolkits, consolidated toolkits that have been proven to work in Nigeria and the rest of the world. And then, if you become part of this, you will become enjoying what we call the global community of practice. In other words, you will become part of the model cities around the world that would be participating in this, and we will be setting up South-to-South collaboration and learning among cities around the world in terms of what they have done in their own setting. So there will be a lot of learnings from cities, either the municipal mayors or the city administrators or the people implementing the programs. Next slide. So what's the benefit for the city when you look at this? So we constructed this diagram. So first, the city brings their commitment to the table and resources to the table. And then they would be trained in scaling up, in the use of the toolkits and best practices and high impact programs. After this, you will have the ability to leverage technical assistance sponsored by the Gates Foundation. You don't have to pay for it. And also at the same time, you have the ability to leverage program delivery and operations fund initially seeded by the Gates Foundation, but could be topped up by other partners over time. And then of course, we would like to see state-of-the-art delivery of services to your urban poor and maybe achieve that demographic dividend in the local context, okay? And then you have become part of the global community of practice. Next slide. So here's the funding model. So the Gates Foundation seeds its money through the Gates Institute, and the Gates manages the money and make sure that the hubs receive the funds, the accelerator hubs. But there's a challenge fund there. If you are a private donor, you can make a decision according to your own personal or foundation priorities or rules. Practice, rejoice and celebrate your early wins. Because sometimes if you don't do the project, you don't develop that morale that you can do it, okay? And again, entrepreneurial spirit and approaches, prudent risk-taking, we will take advantage of that. So I thought I would just share with you this slide. There's two dogs there. It says, it's always sit, stay, heal, right? You command, okay? It's never think, innovate, be yourself. If you were attending a leadership training program at Hopkins, one of the first and most important principles in leadership is be yourself. I don't have time to explain that, but it's a very profound concept. So let me just end with this one last slide. Okay? So who is this guy? D.A. Henderson is one of my public health heroes. He was the former dean of the Johns Hopkins School of Public Health. We honored him with a memorial 2 weeks ago because he died. And he was given a standing ovation by all the faculty members. His daughter read to us what he wrote and said when he was 14 years old. 14 years old. And delivering a valedictory address in some schools. He said, if you think you can, you can. So for those of you who don't know who D.A. Henderson is, D.A. was the guy who led the world in eliminating smallpox. Thank you very much.
Thank you very much. I'm sure you agree this is very attractive and it's indeed business unusual. Open partnership, ownership, angel investing. Since it's angel investing, it must be wholesome. But I won't say more than this because our colleague Lester here has a flight to catch in another 15 minutes. So I'm going to allow him. No, he has to leave here in 15 minutes. Thank you. Thank you. There is no helipad, actually. So I'll yield the floor to him.
Good afternoon. The two occasions I've had to speak at this conference, the first time was when me and the audience was very hungry, so I had to finish fast so that everybody could get to dinner. And today it is, I had a very hurried meal and came here, so I can take my time, but I have a flight to catch, so I'll still be brief. As I think of, and I want to thank owing for really laying out the vision and the strategy for the challenge initiative. But before I make my remarks, and I'll address them primarily to the government officials here, I want to thank a few people. I want to thank Susan Rich and Monica Kerrigan, colleagues with great vision who pioneered and foresaw the challenge of urban poor and reproductive health for the poor, colleagues with a vision to invest deeply in building the evidence of the work that had to be done. I want to thank our partners in IntraHealth, JAPIGO, JHUCCP and FHI 360. Your perseverance, your commitment to the work has yielded this evidence. And I particularly want to thank someone who I know is very dear to Nigeria, my colleague Clea Finkel, who worked with many of you here in Nigeria, who now heads PCI on our team. When I think of PCI, I want to let the government know that we think of 5 challenges. And they're the challenges related to scale. We are not the first donor that has been obsessed with the question of how to take successful projects to scale. Donors like USAID, who have led the field in family planning, have grappled with this much before us. A lot of what we have learned and what we are doing now is built of the shoulders of partners like them, especially through programs like the Implementing Best Practices program that led the field in taking evidence and disseminating and diffusing it. However, when we look at why do good projects not go to scale, we recognize some very obvious challenges. One of the challenges is that the organization that builds the innovation, that develops the innovation, is not the organization that has to take it to scale. So there's a whole transference of knowledge challenge that takes place. The organization that has to take it to scale has no skin in the game. You have to work to make that skin in the game, to have them take ownership for it, right? And ownership doesn't come because you throw money at it. So creating ownership and commitment in the organization that has to take it to scale is very critical. The third is measuring the impact. Show us impact at scale. Just because you did it in 10 villages or 10 districts doesn't mean it can go across the country. And often there is no resource to measure impact at scale. So it will get captured somewhere in a DHS, it will get captured in some large survey. We don't measure and show impact at scale. And the third is, there is a sense that because you have developed something and now you are taking to scale, you don't have to innovate anymore. You're done. And the challenge initiative is saying that we are challenging all of those 5 things. First, we are challenging who will own this. Governments will own this. Whether they are city governments, district governments, they will own this. Why? Because they will pay for it. Without your money, we don't believe you will have an ownership of this. Once you put your money in it, you get the power, like any other consumer, to hold the PCI accountable to deliver in your system, which then sets the incentives for the innovator organization to not just come and do their act and walk away, but to make sure that they are building capability and capacity in your people and your organization to not only implement it as a project, but to sustain that work in your stealth system. The fourth is that the Gates Foundation has committed, and Scott Radloff is here, and Amy Choi are here, to take some of the learnings we have had from how to do more rapid surveys in real time. And you will have data. You will have data that tells you how are you doing on a 6-monthly basis with that investment of yours. You will not have to wait for a DHS. You will have real-time information. And that real-time information will force innovation, the 5th challenge, that you will have to continually improve with your technical partner. And we believe by setting the right incentives in the relationship, we will create the energies that will drive us to impact and drive us to scale. We want to hold ourselves accountable as the Gates Foundation, that we along with the global community made a commitment that we would accelerate progress to reach 120 million women by 2020. We believe that our field is building off the knowledge of the past generations. It will build further knowledge, but unless we have partnerships together, this will not succeed. FP 2020 in its vision is a vision of partnerships. Partnerships for financing, partnerships for innovation, partnerships for measuring, and therefore we believe that through these partnerships, we will achieve that goal. We will achieve that goal not because FP 2020 in 120 by 2020 is an end point in itself, because it marks a milestone that will take us towards the future. And that takes me to my final point. We want to ensure that this platform, the Challenge Initiative, is not about the Gates Foundation. It's not about Nouri. It's not about the urban reproductive health. If there is an innovation that has shown that it can deliver results, whether it be impacting adolescent girls and improving their ability to make better decisions, whether it be innovations that improve and prevent stockouts in the supply chain, whether it be innovations in performance management and accountability, TCI is mandated to continuously source those innovations, build their capacity, and transfer the technical capability into newer hubs. We want to start with the 4 hubs, but we believe that as we learn, we will indeed want to scale up the hubs themselves and have more hubs in more countries. So we are putting a challenge to ourselves too. The challenge to be open to innovations that others have developed. The challenge to fund those innovations in the same way that we have funded this first round of innovations. The challenge of seeking partnerships. The challenge of going out to other donors and philanthropies and asking them to join hands with us. And I want you to stay with that word of the challenge and to think ultimately, why is that challenge important? And close your eyes for a minute and think of that woman, that girl, the stories that each of you want to know, the one that we have failed to reach in time. And that to us is the challenge that we are responding to. The challenge of urgency, the challenge of immediacy, and the challenge of effectiveness. And I hope the governors will look at this as an opportunity not to feel challenged, but to be challenged to respond to the opportunity before you. Thank you.
Ladies and gentlemen, again, it's stressing that it's not business as usual. You all know that when we have projects, once we think we are doing well, we rest on our oars. But what this is telling us is that we have to look at it and think of the possible challenges that we need, that will come up with the project and be very innovative. Challenge and innovation is what this is bringing up tops for us to ensure that what we have put our minds to do, we do very well, we sustain it, we own it, and it yields results. Now we need to talk about the TCI within the concept of Nigeria. How do we locate it within the concept of Nigeria. Even though the commissioners are the ones sitting here on the high table, I believe all of us are very, very involved. Either in your private capacity or working with government, you will understand these better. For those that don't have their commissioners here, you have a responsibility to go back and present this to your commissioners. So let us hear from Dr. Odeku. Thank you.
Thank you very much, Madam Chairperson. My work has been made easy by Oying, setting the tone and let you know why NORI CCP is presenting this. CCP NORI is the Nigerian hub within the global hub. We were part of the initial urban reproductive health global proof of concept, which ended last year. And so I'll present what the TCI holds in place for us in Nigeria. I'll take you through a couple of results that we had under the NORI Phase 1, and also let you know what we're doing in the second phase and how we shall be collaborating closely with the TCI concept and what we shall be also doing under the TCI University. In 2009, when this initiative started in Nigeria for us to prove an innovative concept that can change the landscape in the urban cities where we worked, one of the concerns we had was that when we prove these innovations, how would we leave the learnings within the context of this country? And we were privileged that we had Nigerians on board who were not ready to do Andrew. You know what I mean by Andrew? What does Andrew mean? Checking out. So we were excited that this body of knowledge will remain in here. And we were actually thinking on how we would be able to use this body of knowledge, whether there's a follow-on or a scale-up or there's none, to be able to create a critical mass. We didn't know that TCI will build that out. Now we have TCI. So TCI Nigeria will be helping states and cities to replicate the innovative family planning models in Nigeria that will improve maternal health. And so it's open to both governments, to the private sector, to NGOs, to CSOs. So what's our vision? Since Monday, we've been excited that we've created this family planning movement. The energy is here, the evidence is here, and we've said this is the time to act. So we believe that there will be a true family planning movement with critical concrete actions that will change the landscape of our indicators, where new cities will be motivated, and many have been motivated. I've gotten a couple of states coming to us since Monday, and we said, wait, the TCI is a platform where you can latch on. Partners would ask us for technical assistance. They can take the whole pie or they can take a slice of the pie. It doesn't matter. Whatever it's your need, we are ready to provide that body of knowledge. And they would also provide financial assistance. Like Oyin said, we don't have the money for the full-fledged implementation, because the body of knowledge is here, but we have funds for TA. And of course, the funds for implementation can come from the bilateral donors or the multilateral donors or private foundations like the T.Y. Danjuma Foundation. I'm sure you're wondering why she's chairing this session. It's part of the entrepreneur partnership that's come on board TCI. And there are many more indigenous philanthropies that we will go after to market this initiative, because this is the time now to give back to the community that we all belong to. So this assistance will be used in implementing successful family planning program to match their own investments. So just to remind you again, Oying had actually spoken to this. The NORI model is a will. I'm sure you've seen similar wills like this when we're talking about demographic dividends in Nigeria. The will has to go together. No will can go in isolation and give you the results that we experienced in the cities where we work. Quickly, an overview. The NORI Phase 1 was a 5-year project which started in 2009 till 2014. We had a no-cost extension till 2015, and it was funded by Gates with 3 other countries, Senegal, India, and Kenya. The core partners are Johns Hopkins Center for Communication Program, which was a prime organization, and we partnered with 2 indigenous organizations, the Association for Reproductive and Family Health and Center for Communication Programs Nigeria. We collaborated with DEFCOMS, Advocacy Nigeria, AFON, ADA, and many more. Now, the initial cities were 4 in 2010, and we expanded to 2 more, and we covered a population of over 6 million urban poor. We focused in the urban cities, and that's where you see them as city capitals, and targeting the poorest of the poorest in those slum areas. Now, there were key achievements in each of those wills. Remember, I showed you 3 wills. I won't read this into details, but there were innovations that came to bear. For example, with the advocacy, we ensure we set up advocacy core groups. Advocacy were done by the people themselves, not us. We just provided TA, and that made a difference. And we left back this critical team of advocates for other partners to latch on, and I'm happy to note that other partners that came after we closed that project in those cities have continued to use those. A critical area in service delivery was the innovation of the 72-hour makeover and ensuring that we integrate demand component into service delivery, latched on by the social mobilization component, referrals across board. For demand generation, we use a multi-channel platform, making sure that, like Owen says, no one size fits all. The campaign in Ibadan was different from Ilorin, was different from Kaduna. Early in the morning, I talked about when the Commissioner of Kano was asking about factors, we had data from each of these places where we used to frame the additional factors that would encourage increase in use. So each city had their own, and so that's the science that made the difference. And of course, the overarching campaign was Get It Together. This was a slogan that they all brought up in different languages. Get it together, get your life together, use family planning. And it resonated through every fiber of their life. Now, what critical thing also happened was that NORI opened dialogue about family planning and made it more socially acceptable. At one of the meetings, I gave the example of what the Emir of Zauzau in Zaria did for us to frame the context in Kaduna and gave us the liberty to air his recording across the state, which also provided signature to other neighboring states to latch on. I must say that we were actually excited that what we did in these 6 cities actually diffused beyond those cities, and we have data to show you that, but that will be presented at a later date because I don't have much time here to go on data. So there were dialogues, the open dialogue on FP and on social acceptability. For example, we saw positive attitude towards religious officials talking about family planning over the period. We also saw increase in peer support because we found that's a key additional factor. Nigerians need to find out if their friend supports what they are doing and touch base and find out it is okay. And we found those who were successful users actually becoming the advocates themselves. Now, there was also a shift in myths and misconception. This is a critical ideation that is still here with us. Even in this auditorium, if I ask a couple of people, I will gather a couple of myths and misconceptions. That just means your own idea about family planning, which method you think is best, and which one is not best. Even though scientific evidence tells you the right thing, you still have your own personal views. We found that when we started, many thought contraceptives were dangerous to their health. There was a shift in that thinking. It went down by 14.3 percentage points. Some actually thought contraceptives would harm their womb and actually preferred to abort. You can imagine, you know, and these are not young people. These are married women, matured women. So there's a lot of myths and misconceptions. Some even thought contraceptive will reduce women's sexual urge, which is a paradox to some believing it will promote promiscuity. So there's a lot of myths and misconceptions that still needs to be tackled, but we, through this model of 3 wheels, were able to have a shift in that attitude and a decrease in those myths and misconceptions. Just to show you that there's a high unmet need, as you generate demand, the unmet need also increases. Many women were convinced about using contraception in future, and the proxy of measuring that is intention to use. And in the cities, these actually increased over time. A snapshot of this slide shows you what happened in the MCPR. Next slide. MCPR increase between the baseline and the end line across the poor. You see that there's a marked increase, but the one that actually was very interesting to us was the city of Zaria, the most conservative city in Kaduna State. We scaled up towards 2 years towards the end of the project, and we got this marked increase in MCPR in the city of Zaria. Now, I presented, this gives you the visual impression of how significant this change is, because when some see these figures, then they say, yeah, so what about it? It lets you know that a typical urban Nigeria, CPR increase is usually 0.6%. And if you have this change of 7.6 in Ilorin, 8.2 in Abuja, 10.7 in Kaduna, 12.4 in Ibadan, it shows you that this average actually is the percentage point exceeds the annual percentage increase average in urban Nigeria and also in sub-Saharan Africa. So this is quite exciting to us, and this made us to believe that if this can happen in these cities, it can surely happen in other cities in Nigeria. And that's the inspiration we're bringing to bear under the TCI. I know we're very ambitious people. When we started, we set a 20 percentage point increase, and everybody was asking us, it's not achievable, but we like to think big and act small and act now. Okay, my time is almost up. So, so we have a toolkit. Oyin was talking about the toolkit. The TCI University will provide us the platform to be able to educate people about this toolkit, which slides you want to use, and support you to do that. Now, I did tell you NORI Phase 2 started last year. The NORI Phase 2 expanded to more cities in Kaduna. We're going statewide in Kaduna, statewide in Oyo State, and to a new geography, Lagos State. Now, the scale-up would be collaborating with TCI closely. We've also replicated some slices of what worked in Kano using the advocacy approach that just started last month. Through UNFPA, we are providing TA to stimulate the work in Kebbi, where UNFPA has been working, using the total slice, the total package of the NORI. And we are also collaborating with our sister project, HC3, Family Planning, to take some segment of the demand component to support, and this is funded by USAID, to support Ebonyi State, Bauchi State, and Sokoto State to take a slice of the demand component that's worked and tweak it with the ideation of these 3 cities to be able to make a difference. In Ogun and Ondo States, we are rebroadcasting the radio drama series as well. I'll just end with the last slide. The Madam Chair is on my neck. So further expansion, just to give you that expansion has already started, but we believe that the CCI will give us the momentum for us to spread wide and attend to all the requests that are coming in formally and informally. And Oying has taken you through the steps, but we are the TA that provides the university to hold your hand to be able to take you through scaling up this model. Thank you.
Thank you very much. Had to rush you up because you can see Ejike is behind me here, and he wants us to put an end to this discussion. But it's very important because without the states we are talking to, there is no ownership. So, thank you very much, Ejike. Now, I want the commissioners here to make their, I don't want to call them pledges. Let's have your reactions, 1 minute each. And I will start with River State. You can actually address the crowd from here.
Permit me to stand. The chairman of this session, the Gates Foundation representatives, our development partners, fellow commissioners, participants, and members of the media. It's for me a great pleasure to be invited to participate in this meeting. I bring you greetings from River State and the government of River State. At the level of the River State Ministry of Health, so much is being done and has been done in family planning activities. For the past 3 years, we've built capacities, working with the Clinton Health Access Initiative, the Maria Stopes Group, the SFH, and other teams. We've trained nurses, midwives, community health officers, and community health extension workers. As a matter of fact, we've started the tax shifting since 2014. We have also reached out to training of the private practitioners in the state and working with the partners, making commodities available to them at highly subsidized rates in private clinics and maternities, as low as 20% of what they should pay. This is given by the partners. At the level of the state government and in our facilities, commodities are free. Occasionally, we've heard that they pay for consumables, but we've discouraged that. Now, concerning the TCI, we as a state are interested because we have the capacity built already. We have trained about 293 family planning providers, and more training is going on working with the various partners. We have the structure and we have the will politically. I spoke on the side to Nuri and said, you've not been fair to us. Come to River State. We want to work with you. We have a state that have the capacity to expand. What you're talking about, the urban poor, you can guarantee that, you can be sure that we have that in River State. We have an expanding urban settlement, and we want to reach that group. So the TCI is meant for River State, and I assure you that we are willing, I'm serious, we are willing to fulfill all the conditions precedent and to ensure that we run with the vision and whatever is needed to make TCI work. We will do everything that we need to do, and I want to thank everyone for your contributions, all the partners. I can recognize Nancy, the USAID team, and the FHI 360. Chai, we are deeply grateful. Thank you.
the chair of this session permit me to stand on the already established protocol for want of time. I'm happy to listen to all the discussions that have been made so far. Yes, the Commissioner for Health, Kano State, Dr. Kabir Geso. Initially, I was wondering, we've been talking about Nuri Urban Reproductive Health Project. I've been wondering, why are we concentrating efforts in the urban areas, neglecting the rural areas, especially when you look at the inverted triangle in primary health care, where you have most of the burden of the problems in the rural communities. But looking at what was presented, this is based on the migration data, what was presented, 42% migration by 2015. And by 2050, you are expecting about 72% migration rate. So it's wise to concentrate efforts so as to address this challenge. Well, for our own state, like I mentioned in the morning, we've been putting measures in place to see that we have addressed some of the challenges we have in the state. But in a nutshell, after listening to the presentation, what I understand is this is a challenge to us. The TCI, the Challenge Initiative, is, like it was mentioned by the presenter, is about partnership to come up with innovations. So what we need to do is to go back home, look at the issues, and come up with innovations that will address all the challenges that we have at our states and all the localities that we have. So I want to make a commitment here that politically, Kano State government is willing to, venture into this initiative. We are willing to commit resources in this direction, and we have the system in place. So, like DA, to borrow from DA Henderson, I think we can, and we are going to do it. Kano State is going to do it. So, like I said, we are going to go back home, look at the issues, and come up with implementable proposal that will address all these issues that have been identified. Thank you very much.
Yeah, Madam Chair, thank you. Permit me to sit on the existing protocol. First of all, let me express how grateful we are to Mr. Oyi and Moji for this presentation. I've been privileged to come in contact, I'm from Kaduna State. I've been privileged to come in contact with the TCI project in Bali, sometimes in January this year. I think I will also need to congratulate the Bill and Melinda Gates Institute for Population and Reproduction, or Reproductive Health, for coming up with this model. As a donor, you have gone beyond what other donors have been doing. By default, donors come up with critical interventions, they prove them to you, and allow you to scale up. Why? Because donors do not have the capacity for scale or for permanence. That is why you have to partner with governments, because it is governments that have the capacity for scale and for permanence. So you've taken a step further in ensuring that governments actually ensure permanence and ensure scale. And I need to congratulate you for this. Not only have you given us an innovative family planning model, you have also couched out for us another model that will ensure scale and also ensure permanence. For us in Kaduna, we have a lot that we can leverage upon in order to actualize the TCI in our own state. We have the political will. We shall work hard towards increasing that political will. We have the capacity to mobilize our communities, our cities, in order to be engaged in the TCI. And more importantly, I think you will all agree with me, what is going on favorably for Kaduna is the fact that we have a governor that is forward-looking, very active, and ready to spend money where it matters. So I think for us, I want to assure you that we shall expressed our interest. We shall send our proposals and would want to participate in TCI. Thank you.
Thank you, Madam Chair, for the opportunity to make some few. Here is my name. As opposed to my colleagues who have already made commitments, I beg to differ a little bit. I have listened attentively to the concept PCI, and I am convinced that this is something that we need. Nasarawa State borders the federal capital, and the problems are pretty obvious even as you drive through Mararaba and Karo axis, particularly regarding the poor, urban poor. And the migration, I believe, it's a great problem. I mean, some years ago, they were talking about the rate of increase in Karo area and Maraba area, and it was pretty high as far as the information we had at that time. So the need is there. The issue here, for me, is making an argument for us to dovetail into what has been presented, and also the stages that need to be taken. I think we need to be absolutely sure that we get a grasp of the stages that are involved. So it's not just a matter of commitment without an understanding of what it all involves. But I think we'll be taking it on, because I believe my governor, who is progressive and listens to any superior argument, will most likely come on board. I thank you very much.
Well, thank you very much, Aminu Hassan, the Executive Secretary, State Primary Care Development Agency, Taraba State. I think, ladies and gentlemen, as I have said earlier this morning, that Taraba State is among the orphan states, considering the fact that we are among the states that doesn't have so much partners that will at least support us in delivering not only family planning or maternal and child companies, but other health-related companies. And I think the presentation now on TCI has come at the right time. At the right time in the sense that the state is in their need of this kind of collaboration and believing in our governor, that is Architect Darussi Senishaku, who is so passionate about health, and he even have an adage of rescue mission. I think this is also going to be another feather on his cap. It will also be captured under the rescue agenda of His Excellency, and it has come at the right time because we are in the process of developing our state strategic development plan in collaboration with UNICEF. And I think this project, though I can vouch to say that definitely our state are going to be part of this, but I also need a little bit of time to make a little consultation. But I want to assure the meeting that Taraba State will definitely be among the first line of states to key into this very laudable project. Thank you very much.
Ladies and we've had about 1 hour, 15 minutes discussion on this. We have heard the commitments of the state. The beauty of it is that it's not mandatory. It is voluntarily. And it is the choice to come up to say we want to be part of it. But again, I know that we all want to be part of a good thing. That is not business as usual. That is open, and you can be part of it, and you can watch your investment grow with, the progress you make on the project, and you will have services that will reach the underserved, the people who are disadvantaged. So it is time that we look at it. And it is my prayer that with time we will move away from just family planning to maternal and child health, and indeed to one vehicle, primary health care. Hopefully we will have an integrated approach to funding our services. So I want to thank the Bill and Melinda Gates Foundation, the Institute. Don't forget you are going to university if you are part of it, the Institute, and everybody else that have contributed here. And to Moji, I thank her very much for doing a good job for Nigeria. God bless you all. Thank you.